Thank you very much, Ekene Ndule, for that background. With us here in the Abuja studios to discuss this topic, let's welcome Dr. Basi Okposen. He is Director of Disease Control and Immunization at the National Primary Healthcare Development Agency. Dr. Okposen, pleasure to have you with us this morning.
Good morning, and good morning, Nigerians.
All right, also here with us in the studios is Dr. Iwot Ndayo, is the Acting Executive Secretary of the FCT Primary Healthcare Board. Dr. Ndayo, pleasure to have you this morning.
Thank you, Mike. Thank you so much, and good morning, everybody.
Okay, so let's go to our Kano studio and welcome Professor Sadiq Abubakar once again. He's Director, Center for Infectious Diseases Research at the Bayero University in Kano. Professor Abubakar, it's good to see you again.
Good morning, Claire, and good morning, Nigerians. I'm glad to be with you again.
All right. Joining us from Gombe via Zoom, Dr. Rewanu Mohammed, Chairman, Bauchi State Primary Healthcare Development Agency. And just to add that, Dr. Mohammed is, of course, attending a very important workshop. That's why he's joining us from Gombe. Dr. Mohammed, good to have you with us.
Good morning, NTA. Good morning, Nigerians. Yeah.
All right, Kingsley.
All right, so gentlemen, once again, our pleasure to have you with us. Let's begin with Dr. Basi Okposen, who is of the Primary Healthcare Development Agency. From a few reported cases, suddenly, we went into tens and hundreds, and now we're counting a couple of thousands of cholera. And it appears that there is no let-up in the number of fatalities, and of course, in the number of states affected. What makes this particularly worrisome is that we are dealing still with the COVID-19 pandemic. And here you are, cholera is claiming even more lives than officially, cholera is claiming, more lives than officially reported with the fatalities related to COVID-19. What is your agency reading about the situation?
Okay, let's start it this way. It's true as at today, with the week 37, Nigeria has recorded 73,055 cases officially, with 2,407 deaths. For COVID, as at today, it's 2,668, so COVID is still higher.
Yeah, but
I'm just saying something.
I'm just last year.
I'm just coming.
If you project this one, it's
No,
not
I'm just
into
coming.
next year.
No, I'm just coming. I'm just making it's a by design. It's a by design.
No, but I get the stats. That namely COVID about 2006 and then cholera 2004.
I'll tell you
Rapid killer.
I will tell you the beautiful part of it. Then I'll link to the question you've asked. Between week 36 and week 37, there has been a decline, 88% decline. In week 36, we had 1,182 cases. In week 37, we had 145. There's been a sharp decline, and it's coming under control. That is the beauty part of it. Now, when you look at what the agency is doing, we are not working in isolation. The ones we are doing and the ones we're working in a group, there is a National Emergency Operations Center, which has the NCDC, the MPAC, the Ministry of Water Resources, Ministry of Environment. There are partners that are working with us, where there's a response to it. And then from our own side, majorly also, we contribute to the investigation and management, and then majorly the vaccination aspect of it. There was a time Bauchi was the epicenter. So in Bauchi, we got vaccine through the CWG Global, where they gave the allocation they distribute worldwide. With the support from the Minister, the Executive Director of Faisal, we were able to get half of the global supply monthly to support Bauchi. Earlier in the year, when we had the epicenter at Benue, that was in March, we had the vaccines for them. You could see it died down in Bauchi and Benue. In Bauchi, when they had the cases, in July, we got the vaccine for them. With the vaccination, the cases have reduced by about 94% in Bauchi and shifted base. Just last week, we got additional approval from the CWG Global of about 4 million doses of vaccine, like I heard your reporter also mention, which is to target the 3 states that are currently having the highest cases. The state of the Jigawa is one of them, that then Kebbi and Zamfara, they are having cases. And so those ones, as we're receiving them now, we'll target. So there is a drastic reduction in the number of cases because of the joint response from both the NCDC, our ministry, and then our agency, and then the other partners that we are working in the space.
You know, Claire, yes, Dr. Okpusen says the heartwarming news is there is a sharp decline now in the incidence of cholera, around about 88%. That fine, with the injection of vaccines, we are also seeing a reduction in number of fatalities. But why apparently were we caught napping? We have 2,400 and something persons dead. That's the critical question. 2,400. These are human beings. Why were we caught napping? What went wrong?
Okay. Now, for us to discuss that matter, we need to understand what causes cholera. And then we link, because the government has a responsibility. We as Nigerians have responsibility. The cholera itself is a disease of the intestine caused by infection with Vibrio cholera bacteria. Now, this bacteria will contaminate either water or food. Once an infected person defecates and that disposal is not proper, now we're in rainy season, the rain will wash it into a nearby stream, into a pond where they drink from, into a well if it is not a raised well, and so on. The people go and fetch. That one person contaminating that pond alone will cause an epidemic in that community. Someone goes to pick a fruit, he didn't wash it, and that fruit has been contaminated. You see here, it is not the government that will go and wash the fruit for the person. It's me as an individual that should go to a proper toilet to dispose whatever waste I have. It's me that should go to fetch water. I should know where, and I'll protect that source. It's me that should know that I should use clean water to brush my teeth. I should cook my food well before I eat. I should wash my fruit before I do that. I should keep my environment clean. Once the water source is not good, contaminated, the sewage disposal is bad, and then the hygiene of that environment is bad, it gives an enabling environment for cholera outbreak to happen. And that's what is happening.
You know, Kingsley asked a question, and I was still, because you have to talk to us about the behavior of the bacterium, which is what you have described. I will still get to Professor Abubakar to give us the epidemiology of it. But Kingsley asked a question. In terms of management and control, were we caught napping?
Now, in the management itself, it's also interesting to pass this information across to Nigerians. Cholera infection on its own, usually the symptoms are mild or no symptom, but can be severe. What do we mean by that? Out of every 10 persons that comes down with cholera, it's only one that will be severe. And that one of the 10 will now show those signs. I'm coming to where the management, because the management has to do with both us and the government. In the management, for those that have become severe, what you see is the profuse diarrhea, where we sometimes call the rice water stool. If the person defecates, you see like rice water, it's just watery. Profuse vomiting, and then leg cramps. Once you see those 3 things, on proving otherwise, it's likely going to be cholera. The important thing when that starts happening is to replenish the fluid for the individual. So it's good for us Nigerians to know, whether as a health worker, as an individual, we start with the basics, the salt water solution to rehydrate the person. Because that rehydration is what most times results in shock and death. But if that is attended to early, even before the person is taken to the hospital, it is when the dehydration is at the extreme that you can now administer drips, which is now the responsibility of the hospital. And then once that is done, we can now prophylactically add antibiotics because the bacteria, with the antibiotics added, it drastically reduces the possibility of the person dying from the disease. So it starts with us, for us to be able to ensure that once we notice a sign, we take emergency steps and then report to the nearby facility for help. And then on the government side, once the cases came up, what the government did was immediately to set up the National Emergency Center for the Cholera Center, got the commodities that are needed to support those states that were affected. And that was distributed to the NCDC to the affected states. They were given free. They went to the site. Also, they contaminated the water sources for those that the water sources were seen as the primary source, and then provided the basic antibiotics that were needed in those treatment centers for the person. And then from our agency side, we made effort to get the vaccines to the affected state. I will interest you that with the support we've had from His Excellency the President, the Vice, and the Minister himself, and the Executive Director, Dr. Faisal, for this month allocation of the ICG's vaccine donation global, Nigeria has taken 100% of the supply that should go to every other country.
You know what?
Just to support.
I'm sorry. You know what I like, to find out is from 22, and now you say the epidemic is in how many states? 29 states?
27.
27?
But
it's
no,
almost,
it has gone down.
And the FCT, hold on, and the FCT. What I'm saying is, at the point where it started, where it was just 4, where it was just 5, where it was just 6, what happened? Is it that we're not able to diagnose quickly? Is it that we're not able to provide treatment quickly? How was the response, strategy, mechanism from the primary healthcare? Or there are so many people.
You know, you've asked a critical question. I will still link it to one thing. Aside the government, we Nigerians had a role to play for one reason. I'll give you an example of a state. The commodities were available for them to receive. They were informed. These commodities are available for you. One of the early states, come and pick. It took the state 4 months to go and take those commodities to support. Even with the effort that went to support the state to get those done. 1, 2. For us Nigerians
what
also.
What states are those?
We leave those ones.
No, but
now,
I mean,
for Nigerians themselves, like we mentioned how the infection can occur, there have been announcement PSAs on the radio, television, advising Nigerians to please ensure that their fecal disposal is good, to ensure that at least they boil their water. If they cannot get the water, pipe-borne water, boil it, keep their water safe. But people still are careless about the water they drink, the food they eat. They leave them open for flies to contaminate those foods. It's like what we are seeing in COVID, where people are being advised, please use your face masks. They don't care. You go to the market, they will tell you this. So the attitude is there, but the government has been making effort to go to those areas, identify the cases. If not the early intervention that came, it would have been far worse than did this year.
Okay. Thank you, Dr. Oposan. Now, let's go to our Kano Network Center. Professor Isa Sadiq joining us from our Kano Network Center. Professor Isa Sadiq, Kano has also been hit hard by the cholera outbreak. We know that on a per capita basis, the number probably will be less than what you find in some other locations. But certainly, hundreds of persons are reported to have died from it. What is it that we should know about the cholera outbreak this year in Kano?
Well, thank you very much, Kingsley. Cholera outbreak, as you said, has affected Kano just like other places. One thing I want people to understand is that Kano is the most populous state in the country. We are not talking in terms of population density, but in terms of absolute number, Kano has the highest population. And you know that a good number of our populace are within the municipality, engaging themselves in a lot of activities within the cities. And of course, because of the population that is explosive, There are a number of places where you find cases of open defecation, which is an avenue for the transmission of these bacteria. And a lot of places, in spite of the effort made by the government to provide water supply, still we have a number of places that are battling with shortage of water. And the rainy season, of course, you know, in these years have been massive, causing a lot of flooding. And just like Dr. Basi has said, these are situations that warrant heavy transmission of the disease, and of course a place where a large number of people are living has not been spared. When you look at our rural areas again, it is the same picture. We have the situation where flooding has affected many of the dwellings where people live. And of course, because cholera is transmitted fecal-orally, it is a disease that can easily be passed, because there is no way that people will not take food and then they will not take water. But since our level of personal hygiene is still very low, simple hand washing is still a problem to many of us, and then the issue of safe disposal of feces is not there. Open defecation is the order of the day in many of our communities. These ensure that the disease is being transmitted. And that is why Kano has not been spared, just like other states in the country, with the epidemic of cholera. Of course, we are living in a country which is endemic for cholera. And of course, because cholera is an epidemic-prone disease, these situations, as a result of the environmental conditions, as well as the properties of the bacteria itself, and then the human behavior, the triangle of epidemic has been completed, because all the situations you need to facilitate an epidemic are there in our environment and among our people, and the bacteria is still getting transmitted. But it is heartwarming that we are hearing from the government some effort is being made to address other issues of control, apart from the one that should have been the easiest, but it is proven to be difficult. That is on the part of the communities to do what they can to ensure that they do not get this infection. Thank you.
Professor Abubakar, I'd like to stay with you. I just want you again to look at the behavior of the bacterium. We've been dealing with this problem for a very long time. Last year, we had cause to discuss cholera here in the studio. Dr. Poulsen was here with us. And we also had the representative from Bauchi and all that. But the interesting thing I discovered is that, from research, is that with each outbreak, the case fatality is set to be higher and higher. What is happening? Is it that, are we having new strains that are becoming, drug resistant? Or is it that, I don't know, the other conditions, that precipitate the disease are getting worse?
Well, this can be multifactorial. Of course, in terms of cholera, 2 variants or subtypes have been identified, the 01 and 0139. But for a long time, in most cases where you have the epidemic, it is the 01 subtype that is causing the epidemic or pandemic. And in such a situation where you have that bacteria, it is also behaving in the same way as viruses do. Of course, there is an aspect of mutation which tries to ensure greater virulence, and at times, because of the increase in the number of people we have, the epidemics spread faster, and affecting larger number of people. But then, of course, there is a property of the bacteria itself which allows it to be more virulent and then to cause a more fatal disease. And of course, researches are still ongoing to discover more factors that might explain the increase in the lethality of these bacteria as well as other organisms.
Okay, thank you, Professor Isa Sadiq. We'll return to you subsequently. Let's go over now to Dr. Riwan Mohammed, who is of the Bauchi State Primary Healthcare Development Agency. Dr. Riwan Mohammed, again, I want to ask you the same question I posed to Dr. Oposen. Was Bauchi State caught napping in responding to the cholera outbreak, which from just a few cases suddenly became an explosion and turned Bauchi into the epicenter of cholera outbreak this year?
Oh, thank you very much. Since we had the outbreak of cholera in 2012, 2014, 2018, and the next one is this 2021. So it is not a new thing in Bauchi State. And one of the factors we realized that could be the reason why this outbreak is going is one of this, as my professor said, is open defecation. And when the first rain came, it washed all the stool into our well and other places, and we swallowed it, and the outbreak started. The second reason why this outbreak occurred is because of lack of enough water supply, clean water supply. And then people are resulting in using all sorts of water without knowing where the source is. The third one is the issue of the new fruits that came in at that time, vegetable fruits. People are not washing it, are not washing their hand. This is the three reasons why this outbreak occurred in Bauchi State. And then when it started it actually started in the border of Kano, Magami, in one of the wards in Ningi local government. The outbreak started gradually with the first index case, then later we had it in Bauchi. It spread to 19 local government in Bauchi State. Only one local government has one outbreak and death in Bauchi State today. So what we did actually was to wake up quickly and then set up an incident management system, and our mitigation plan and costed mitigation plan was done with our partners. Then we informed the NCDC. Actually, this is their work, but there was the former DG of NCDC. I must say that he did not respond very well to this epidemic, because it's not only money, but technical support is also required. But we did not get that support. The former DG did not give that support, but we did our best. The governor of Bauchi said all patients should be managed free of charge, and we did. We had 3 isolation centers in Bauchi town, and then where we had a higher number of cases, higher number of deaths of cholera. Then we manage them. Later, we realized that we cannot manage them in this multiple isolation. Then we invited the Action Doctors Without Border, who came in to erect a cholera treatment center in Bauchi, where we manage all our cases. Almost 9,648 cases were managed in that center. Then we had another treatment unit in Toro. And all our general hospitals were turned into isolation centers and managing those cases around there. And one beauty thing that we got from the NPSCDA is a vaccination. And that 1.5 million doses of vaccine that came in July, we vaccinated the first dose. Now, all the cases have drastically come down in all the local government, even in Bauchi that has the highest number of cases. We gave the first dose, 750,000 doses. Then we gave the second dose, 750,000 doses. All the people that are coming on admission are those that are not vaccinated. Only 16 out of the whole people that came in after the first dose of the vaccination, which gave 60%, 60% of the protection. The second dose gave 3.5 years of protection. Those that came in on admission will realize that only 16 were those that had the first dose that came in. So, and what we did also was to make sure that we set up pillars, 7 pillars, case management pillar under the incident management system, like we did in Folio. We have the risk communication, and all of the research pillar, which I'm the chairman also of that pillar and the chief investigator, we are finding out what were the cause of this. We almost completed the research issue. And then logistic and management supply of IV fluid, which is very expensive, ringers lactate. We are, the government of Bauchi say we are buying it for every individual. Now, as I'm talking to you now, 17 LGAs beside Bauchi State has to move to Bauchi State to collect treatment, which are our borders. We have to take care of our borders. We give them free treatment, and we are doing that for a long time. And then what we also did was the government of Bauchi State also was to actually make sure that we increase the awareness to the community by mobilizing what we call our community volunteers. We had 200 community volunteers, which has gone to about 500 houses, talking to them about good personal hygiene, talking to them about hand washing, and then also decontaminating the household where there's infected person from the line list. They're also doing the well chlorination if there's well. Now we have challenges at that time. So people that have well say they have fish inside that you cannot chlorinate. Those fish are more important than human being. And that was the cause of the thing that has not, that prevent us from controlling cholera in Bauchi State. About few communities refuse decontaminating on some of their wells they have in their villages and places. They say they have fish, which is originally from their grandfathers, and you cannot touch those wells. And that gave us a lot of problem of if there's infected person, we have to decontaminate the first house, the one on the other side, on the left and the right, and even 4 houses within that area where we have the outbreak. Now, what we did again, in case there's an outbreak in one community, we gathered the whole community. They have knapsack spray, which they use for the agricultural produce. We ask them to now, we give them chlorine. They put inside the knapsack spray. We now ask them to decontaminate their whole household with their children and the youth of the community. That has helped us a lot in decontaminating the households. Now, another thing is the support of another organization like Action Against Hunger. UNICEF came in, WHO came in, and then we really had that support from this organization. The Action Against Hunger supported us actually in also mobilizing the community by engaging community mobilizers to actually carry out this activity to reduce the number of cholera cases. And then that was what we have been doing. And now the cholera cases has drastically come down. Only about 2 or 3 local government are reporting cholera cases as of today.
Okay, thank you, Dr. Rewanu Mohammed, for all that you have done. And we are glad that, the cases have come down and you have just few LGAs. But I'm going to ask you, because you talked about open defecation and access to safe drinking water. And we are told that the conditions for cholera are preventable. So what is the major challenge? Maybe we can use Bauchi State as a case study for other states. What is the fundamental challenge for states in controlling or even preventing it? Because all that you have rolled out seems to be recurring. Last 2018, you probably did the same thing. Last year, you probably did the same thing. Maybe next year, if God forbid, say cholera outbreaks, you follow the same procedure. It's become routine. But we must address the fundamental conditions, that make cholera, thrive. So what do you think is the major challenge for you?
Now, we already informed His Excellency, the Executive Governor, that what we realize is the issue of water supply. And then what he did is urban renewal. Bauchi town actually is an urban slum because some areas are really not conducive for human because they are very close to each other. You see a house with the fence. On the other side is a well, and he doesn't know even there is a toilet on the other side. So it's a big challenge. Now there's an over 65% of the piping of water in Bauchi State has been done, remaining about 40% of the piping. That is the major thing that can be done to stop this cholera outbreak. When there is enough water supply, I'm sure that can stop the outbreak completely, and the government has already agreed. The second thing that we advise His Excellency, we wrote a memo, he has given approval, is to make sure that we erect PPP toilets, probably private toilet in strategic places for people to use themselves when they are impressed. They want to take care of themselves. When you don't provide a place, they will naturally go to run about other places and pass open defecation even in the main town like Bauchi town, which is the state capital. So the government has approved that they are going to erect this multiple PPP toilet within the town so that people can take care of themselves. It's done in the motor parks and it's done in some places where if you go to motor parks, you pay some certain amount of money, take care of yourself, very little talking amount, and then you'll be okay. So that the open defecation is one of the major things that I realize. The second one is the water supply, which he has taken up the matter. He's taking care of Bauchi town. The next one I had is Azure town, which is the next to Bauchi, and other places. He's doing multiple boreholes in all the places. He has done 648 boreholes. He's built and constructed 648 boreholes in villages in Bauchi State today. His Excellency, the Executive Governor, said that he must stop this cholera. He doesn't need any support. Since the NCDC does not do their support, he should do his own to take care of his people. Now we're helping other states. They came here to actually ask us, what are we doing? We show them our structure. We learn from what we are doing in polio and NCDC and MPSCD, and the structure was strengthened. His Excellency gave us all the financial support. That's one most important thing. And people are treated free. The drugs are free. Even the commodities are free. All the IB that's expensive, we have to buy it. He said we must get those IB anywhere they are at any cost, and let's take care of our people. And now the cholera has come down. I'm telling you, it's going to be history in the next 2 weeks in Bauchi State.
I was just wondering, there's a matter that is hanging there, Dr. Rewanu Mohammed. Twice now you have mentioned that the NCDC did not respond promptly to the cholera outbreak in your state. The NCDC is not part of today's conversation, so they are not in a position to immediately respond to your claim. But what did you expect the NCDC to do that they didn't do? And what was your own step as a first responder, that's to say as a state government or as a state agency or otherwise, when you had this outbreak from one border location with Kano, suddenly it went to 19 local government areas?
Now, since the outbreak of COVID-19, we have been discussing and managing and coordinating by MPSCDA. Today, I must congratulate the ED and the Minister of Health. These people are coordinators. These are good managers. What the NCDC, before he left, he has not called any meeting. Now, in the whole COVID-19 period, we have only 17 people that died. Let me tell you today, in Bauchi, officially, we have almost 280 people that died officially, not unofficial one. 200, 300 people have died today or more. Now, more people got infected like the other previous condition, which previous years. Now, there's a meeting with MPSC. They're discussing about COVID-19 vaccination. Who is infected? What is the problem? How can you now do the data management? They send people. The only time the NCDC sent, we wrote letters first when there was an outbreak to NCDC. They should respond. They said they are going to do something. They didn't do anything. So after we have finished, we also discussed with the NCDC that, look, we need support. They sent about 8 people who came to carry out only investigation to find out the cause of cholera, on which we are already doing. Well, I'm already the chairman. We have about 5 consultants, public health are there already doing the work. Then we now say we don't need their support. We thank them, they left. Then they did not give any support in terms of coordination. Now, the MPSCD, we had meeting last week with the ED National Primary Care discussing about our variance between our image data and our calling data. How can we support it? Who is not vaccinating well? What is the problem? Nobody is talking to us in NCDC except the Minister of Health that called about 4 meetings to discuss the issue of cholera in Nigeria. The NCDC did not feel it is important, and that is not right as a country. When we talked to them, they said it's not on, cholera is not on concurrence list. Now, the COVID-19 is on concurrent list. Is COVID-19 on concurrent list while we are working with MPSCD, trying to see how they do their duty. Even when we are asking for vaccine, they gave us 1.5 million to support of WHO. Now, the NCDC did not do that. They support during the MPSCD. The other one maybe is because of the committee headed by the secretary to the government. The Bauchi State came at a time when we have a higher number of cases. The control was very difficult. We need also major technical and coordinating support that we did with the MPSCD. We always discuss with the ED and the other directors. Look, what is the way out? How can we solve this problem? That is the way a nation can do. Not only necessarily money, but technical support sometimes and direction can let us know where are the problems. How can we solve those problems? That was the reason why I always quarrel with them. And they know that we quarrel with them because they do not do their duty properly by coordinating the matter. And I think there's a new DG now. I think maybe the thing will change.
Rwanda Mohammed, thank you very much. We'll get back to you in a moment. But let's come back to the studio, Dr. Ndeyo. We have kept you, and there's a the reason for that. I'm shocked. I know that we have rural areas in the FCT, but tell us, what was your first response, and what was the role of the NCDC and the primary health care, in containing, the spread of cholera in the FCT?
Well, thank you so much, and I'm so happy that I should come in at this time. I've got the privilege to also listen to about 3 speakers on this topic, but I must say that to me, it's a great embarrassment that we should be talking about cholera outbreak in this country, for that matter, at any time. When there is a breach between excreta and human being, human excreta and human being, then you have this kind of situation at hand. So somewhere we have got it wrong, and we have got to accept it. And you look at the situation that normally, in a normal response situation, that is when you are preparing to respond, or preparing a community, a family, community, local government, state to respond to epidemic, that the country has specified and very clear structure and system to do that. We have the knowledge, we have the personnel to man this system from the community to the national level. And we have appropriate reporting system. We have the tools that weekly, there's a Form 001 that is used for monitoring and reporting weekly, and you are sending that to the center based on the data that you are generating from your daily activity in the clinic or in the hospital or wherever you are seeing clients. So for instance, I'm here in Community A. I have a facility I'm manning, and I've noticed that cases of severe acute gastroenteritis, let us put it that way, because cholera falls within that. You also have Klebsiella, you have E. coli, you have Salmonella. They all will cause the acute severe gastroenteritis. You now see that you are having 0, days, suddenly you started having 1, 2, 3, 4. You should raise, you trigger, the system should be triggered, and somebody must take responsibility. So are we doing that? We are having diseases. In fact, when this country was certified wild polio free, 2020 August, Dangote Foundation and the Bill Melinda Gates Foundation said they are shifting to surveillance. Surveillance system is what I'm trying to describe to you now. In the primary health care, we have what is known as community informants. They are there in the community to do what you are doing in the clinic, actively monitoring the communities. Are there cases, but what are the diseases that are included in this monitoring? You have the polio, you have the acute flaccid paralysis, you have diseases that have been built for eradication and control. They are all there. So we should also expand so that people will be looking for cholera, cerebrospinal meningitis. You should be giving community definition of these diseases so that the community informant should be updated regularly, and then the linkages from them to where they respond in terms of practical intervention when the outbreak has occurred could be established. So these were not happening for cholera. And look at it, this is a disease that is seasonal. Just as we have said, there is a breach that human excreta has come into the buccals of a human being and is causing this. What is the health-seeking behavior of our people, residents of FCT, to be specific now? Did they look at this situation as being warranting hospitalization or hospital treatment or visiting the clinic? And if you follow that trend, you are locating where the outbreak is happening. Is it happening in the cosmopolitan? As you rightly said, it is less than 1% of the total FCT that is cosmopolitan. 98% of communities in FCT, over 2,000 communities, they are rural. They live in filthy, unorganized, community. Even when the rulership, the leadership of the communities, at times may be indeterminate. And then you see these people not having food security. Rainy season is when they are going out there to farm, to crop. The community is completely, dirty and not being kept. They are in the farms. And they are eating food, drinking from the open stream and all that stuff. And they come down with this. We had this issue 2009 in FCT. And when government intervenes, you don't expect the situation to continue more than 2 weeks. That is when you talk of epidemic curve. When you see a situation that is persisting after a week, 2 weeks after government has stepped in, experts have come in, all the partners supporting surveillance and outbreak response, disease control should come into a matter, and it's lasting over 2 weeks, then there is something wrong. Something is wrong somewhere. Either we are not doing surveillance enough, or we are not targeting the appropriate agents. Because yes, it's good that we are having cholera, but I also understand at this time in FCT, we also had to do general stool analysis culture, and we realized that things like salmonella, the organism that is causing typhoid, fever, the one that is known as Klebsiella is also there. We have E. coli, which is the one that you see in freshly contaminated water source. So that we have seen that. And we remember a case that we took the water source to the laboratory, and the laboratory scientist was raising an alarm. Is this actually water or excreta? Because the water itself was like excreta. And this is what our people are taking. So we have
What's
got
the situation now? Sorry.
No, it's fine. I think for the past 3 weeks, FCT has been reporting 0. We don't have any cholera case in FCT in the past 3 weeks.
So the outbreak was more in the rural areas of the FCT.
Exactly. So the location is very key. And when you are talking about potable water, yes, it may be coming out from the pipe, potable. But what is the receptacle? Where is it stored? How is it stored? Because you have your utensils, you have your storage bowels and pots contaminated already, and you put potable water there. I mean, you don't expect the effect, to be positive. And remember, the ED said that the cholera vaccination itself is reactive. That means the disease is already there before you are vaccinating. So that is to say, we got it wrong from the outset, and we are trying to correct those wrongs. So we have got to do what we should do, and remember that if you don't start on time, you have a situation in your hands. If you are looking at cholera coming in the rainy season, what should you do before the season comes?
That's right.
Thank God that God has already given us the beauty and the privilege to determine when this disease would come in, the outbreak will come in. Cerebrospinal meningitis, the brain, would come in the early dry season, where is the best time to give preventive vaccination. We are looking at about 3 months to that time. So that means if you want to prevent cerebrospinal meningitis in February or March, you should start vaccinating people in October or November the previous year. So we are looking at, so we should rise to the occasion and not be reactive most of the times in this country.
Who are the we?
That should be Federal Ministry of Health, NPSCDA, the state government. I mean, it is everybody's responsibility because, as I've said, there's a system to trigger the signals that, we are approaching the season. So what can we do to protect our people so that we reduce the reaction?
Okay.
We are in the season now. What should we do? Do we just say, cholera? But these are all group of severe acute gastroenteritis. All of them are capable of causing profuse diarrhea and death from dehydration.
What did you do to bring down the cases?
So what we did in FCT, the judges have said that we have to activate all these systems with our partners. The NCDC, the WHO, they are table partners in FCT. They are very supportive, and they are very good. We set up the EOC. In public health, we had the incident manager, we had multi-sectoral representation in that place, water board, rural water sanitation agency. We had works, and we pull partners together and strengthen the community surveillance system. I think that is what I would come in here. And we also had to analyze these tools. We had to analyze these tools from the 6 area councils. We analyzed these tools beyond cholera to also expand the scope of antibiotic therapy. So because the antibiotic you may be using for cholera may not be active against other gram-negative enterobacterial cells. So we did the culture and we isolated these organisms that have also mentioned. So we are approaching a case. We give this combination of antibiotic, and you could see that within 6 hours that you may be taking care of that. And again, the Minister of FCT at times behaves as a doctor. I don't know, medical doctor. Well, we had the case in Buhari. Yeah, actually, the number of cases in Buhari wasn't as high as the number of cases in Abuja Military Area Council and Golada Area Council. But he noticed from her presentation that the number of deaths in Buhari were higher than this other one. So he had to ask us, why was this happening? So the epidemiologists that we got down there and we found out the water source, we were able to track to the water source. And as I speak to you now, as we're given approval and hand pump borehole has been installed. And I mean, and so we are doing Gwagwa and all that. So we are doing that. And the risk communication is good. But then giving people general information, oh, don't wash your hands after toilet, do that. Open defecation is good. But then if you cannot go to a situation that you have a community that is having the outbreak, and you are telling them that is the source of your outbreak, that water source, that food source sort of stuff, this is what is causing your problem. Don't do this, don't do that, and people will be safe. That is fine. Okay. So you go beyond general
Dr. Ndayo, thank you very much. Thank you. We know we paused you for a while before we brought you on. But I just would like Dr. Bassi Okposen to also tell us a few things more about the vaccination program for cholera. How long does the potency of cholera vaccination last? And is there a nationwide program for vaccination, and who should get it?
Okay. You see, thank you for the question. Just to correct an impression first so that Nigerians will have it right. Currently, globally, vaccines are not produced for routine vaccination. They are more of reactive because the companies producing it are few. In Africa, as we are today, it's only Liberia. They are trying the conjugate vaccine. They have a smaller population to see how it works. And the country being proactive is already in dialogue with Gavi to see the possibility if they are going to give any other African country a chance to be part of it. We are already set to submit a proposal whereby if the vaccine is available, we know those states that every year have these cases because the preventive measures are not taken. We can pre-position the vaccines for those states. That is the target of the country. We are at the verge of getting Gavi consent to be able to submit a proposal to also start a pilot. Now, for the vaccines that are available, one dose, if taken, the first dose taken, confer immunity for about 3 months to 6 months. But when the person takes a second dose 2 to 6 weeks apart, it gives 3 to 6 years protection. And for who can take the vaccine, majorly is from 1 year and above. And when we see the cases that we have had in the country so far, majority of the cases, over 60% recorded in Nigeria this year, are between the ages of 2 and 14.
2 and
14 years.
14?
14 years, that recorded about 60% of the cases that we're seeing. So all these things are away. And like you mentioned, giving you additional information on the vaccination. And remember earlier, I commended the President, the Vice, the Minister of Health himself, and then the Executive Director, Dr. Faisal. On a monthly basis, the ICG International Cholera Group that is responsible for giving the vaccines for reactive campaigns, on a monthly basis has available only 3 million doses to distribute to every country in the world.
Dr. Person,
for July, we took 1.5 million of that source alone. This month, we are taking the entire 3 million, plus one that will be added again next, to show you the effort that the country is making to make sure that whatever is available globally is there for Nigerians for them to be vaccinated. So, and we also hope once there are windows, more production, and the vaccines are available for routine, we will pre-position those vaccines in our various states to make sure that people are vaccinated ahead of those peak periods.
I don't know. I
sorry,
think things
Kingsley.
have changed.
Yes.
I just want to make a comment, not to ask a question. When we went for our orientation exercise in the NYSC program, we had two forms of vaccination. I believe one was for cholera, and then the other one was for CSM, that's cerebrospinal meningitis. Maybe that was there in the camp. Maybe the question to also ask, probably not for this purpose, is, look, is globalization affecting vaccine production? Because we keep saying donors. We can't produce vaccines here. I don't know.
That's a bigger subject, Kingsley, to take. But let's take the final question from Professor Abubakar in just 60 seconds, if you may. What will be the first line therapy, when cholera is suspected, before you even get to the hospital or before you even reach a professional treatment?
Okay, thank you very much, Claire. The golden measure to take is oral rehydration solution. We know that we have this WHO/UNICEF formula, which contains sugar and salt. People should make the best use of it. As soon as we suspect any diarrheal diseases, the first thing we should do is to mix this oral rehydration solution in 1 liter of fluid, and then people should take it profusely before they even get to any health facility for help. They should start taking it at home, and even while traveling to the health facility, they should continue to take it. But severe cases, we shouldn't even wait. While we are taking these measures, we must get to the nearest treatment center for cholera, where they must be placed on intravenous fluid. That is the golden thing to do. And then, of course, the antibiotics will help to reduce the duration of the diarrhea and then the impact of dehydration. And one thing we can do for children, zinc solution is also helpful because it reduces the duration of the diarrhea. So to repeat myself, oral rehydration solution before anything. Even if the patient is still vomiting, we must continue to give after a while because it helps.
Okay, Professor Issa Sadiq, thank you very much. This ORT, some years ago, you could hear it on radio, on television, see everything, ORT, oral rehydration therapy. Particularly amongst children. And from the data that Okposon has given us this morning, if you have about 60% of the fatalities occurring amongst children and then early teenagers, we must ask the question, what happened to the campaign on ORT? But that question is going to Dr. Rewan Mohammed of Bauchi, who of course will join us via Zoom from Gombe. What is it that we can do to ramp up public enlightenment, in particular the WASH program? Because if you look at the numbers now, it would appear that the WASH program has not been a success in some of these high-impact states.
Thank you very much. We actually step up our risk communication pillar, and the risk communication pillar link up with both traditional rulers, the emirs, the district heads were all involved in this massive campaign to inform the people about when there's cholera in Bauchi town, there's cholera in the whole Bauchi, because person-to-person transmission continues in the market, in places where there was wedding or anything. So we inform the people. The next one is informing the religious leaders' sermons during Friday prayers, during church service on Sundays. We actually go there also to inform them about the behavior. Our behavior is what is propelling. If we don't change our behavior, there'll be cholera, continuous outbreak of cholera. Washing our hands after eating, after going to toilet, after shaking hands with people, before you do anything, We intensified that during the Friday sermons and then in the church services. And that has helped us a lot. And in the radio and television, we had a lot of jingles going on in different languages to inform the public to be aware of what they drink. If they are not sure of the water they are drinking, they should boil the water. Then we also go on to carry out compound meetings, radio discussions, actually ask questions so that we answered point-in, call-in programs, so that people will understand the way the cholera get in and how can it be prevented. And that has been the thing we have been doing. We didn't see the reason why is it that the cholera has not stopped until this vaccination came in. I thank God that there's vaccination. Now they're asking of, they don't like COVID-19 vaccination and they like cholera vaccination because they saw that it's killing a lot of people. And then we have only 17 people that died in Bauchi for the last 2 years. So we're going to stay this risk communication activity in Bauchi, and that will continue. Thank you very much.
Nigerian thing, that you are seeing the fatality they occur right in front of you, with cholera, dehydration, stooling, vomiting. So, unlike COVID, COVID, the person can just have it, and then the next thing,
Dr. Ndeyo, your last question in 30 seconds, please. What leave do you think we can borrow from public response, to COVID-19? What leave can we borrow from that so that, to address cholera issues?
Okay, thank you so much. I believe the COVID-19 pandemic response and preparedness and response in the country has really helped us to strengthen our response to the cholera. The problem was that the fit in from the community aspect was very slow to come. And we want people, the behavioral change communication and the active, the health-seeking behavior of our citizens should be improved to become very active. They should be actively involved. I take responsibility because the primary health care is closest to the people and linking with the people. We should be able to bring them to the situation that they can now actively seek for health care when they are sick and to prevent sickness. Right. And then lastly, I want government to key into the UN definition of access to potable water. That by this time of the year, we are still giving community points of water source. Reticulation is not highlighted. I want to say that by this time in this country, we should be reticulating right to the households. Right. We want households to turn on their tap and have their water and not to take a queue up in a community center to fetch.
All right, so Dr. Ewart Ndeyo, Acting Executive Secretary, FCT Primary Healthcare Board, PHCB, would like to thank you for your contribution so far. Let us also thank Professor Isa Sadiq Abubakar, Director, Center for Infectious Diseases Research, Bayero University, Kano. Professor Abubakar, thank you very much for joining us. And Dr. Rewanu Mohammed, Chairman, Bauchi State Primary Healthcare Development Agency. He joined us via Zoom from Gombe, where he's attending a workshop. Many thanks to you, and congratulations for the success you have achieved so far. Finally, let me appreciate Dr. Basi Okposen, as always, Director, Disease Control and Immunization, National Primary Healthcare Development Agency. Thank you very much for joining us. All right, let's take a short